అసలు యూట్యూబ్ తీసేసేయండి, వేస్ట్ న్యూస్. దానికన్నా గూగుల్ మీట్ ఏదో పెడితే మాకన్నా కనబడతాదో అక్కడ ఉండదు.
ఇప్పుడు ఇది కూడా మీరు చూడదు సార్, మీరు మీ ఫోన్
తప్ప క్లాస్ 3 people ఆన్లైన్, 2 people ఆన్లైన్, వాళ్ళ కోసం క్లాస్ తీసుకోవాల్సిన అవసరం లేదు సార్.
పీపీటీ ఎక్కడ ఉంది సార్ ఇది?
నేను పీపీటీ వాడట్లేదు.
ఓకే.
Sure. I had taken a whole class as very important topic, and that did not come as a recording. So now I'll be taking the class again. What can I do? Nothing more. So first and the foremost is I'll have to finish it off a little quicker. Benign disorders of the breast, nipple, especially nipple disorders. There are two types of nipple disorders. One is slit-like nipple retraction and one is circumferential retraction. Circumferential retraction is seen in CA breast. Please remember. Slit-like nipple retraction is seen in ductectasia and chronic periductal mastitis. Chronic periductal mastitis. So discharge from the nipple, okay, if it is from the surface, it is most likely Paget's disease of the breast, of the nipple, eczema, psoriasis and a canker. Discharge from a single duct. If it is bloody discharge, it is most likely intraductal papilloma, intraductal carcinoma, ductectasia. Again, in serous discharge, it could be fibrocystic disease of the breast, ductectasia, which is also green color discharge, and CA breast. So any discharge, you should have a high suspicion that it could be malignancy in a case of CA, in a case of breast nipple discharge. Is that clear? Discharge from more than one duct. If it is blood stained, it is carcinoma. It could be ductectasia. It could be fibrocystic disease of the breast, as well as fibrocystic disease of the breast, as well as it could be ductectasia. 1 minute. Hello? So what would I do? Regarding? No, thank you. Okay, blood stain discharge from more than one duct. It could be carcinoma, it could be ductectasia, it could be fibrocystic disease of the breast, as well as ductectasia again, if it is black or green color discharge. If it is serous discharge, it could be fibrocystic disease of the breast, ductectasia and carcinoma. What is the investigation that you perform? You will do a ductography. Most common indication for ductography is nipple discharge. What do? You inject a radio-opaque material into the duct and then a mammography is taken. Okay, you take a mammography and that will give you a feature. So there are 3 findings that is possible in case of nipple discharge in a case of ductography. Number 1, if it is ductectasia, there should be dilated cystic structure. Okay, you will see a dilated cystic structure. If you see a duct papilloma, it is a small filling defect. You will see a small filling defect. And if you see carcinoma of the breast, okay, you will see irregular masses, or intraluminal multiple filling defects. Then treatment. If it is intraductal papilloma, there is 2 types. Two things you do. That is microdocotomy. You do a microdocotomy, as well as you can do a Hatfield's procedure. In microdocotomy, if it is only from a single duct, you will send a probe and give a incision. You will give a tennis racket-like incision, and you will remove the papilloma. And usually it is about 4 to 5 centimeters from the nipple. Okay, the duct papilloma or ductectasia is located about 4 to 5 centimeters from the nipple. So that is where you do a racket incision and you excise it in total. And then there is Hatfield's procedure, in which you will take a conical incision. Okay, conical incision, and you will remove the entire duct. Okay, when do you do this? When you cannot trace out the duct ectasia from where it is coming. So you'll remove the entire duct, and once you remove the entire duct up to the pectoralis fascia, the problem is this breast cannot be fed anymore. That breast cannot be fed anymore. Okay, the patient can have nipple retraction in the future. Okay, nipple loss of nipple sensation. Okay, because you're removing a major duct from the subcutaneous tissue until the pectoralis fascia. So basically, two things of the breast that you should remember: eczema and Paget's disease. Right now we are talking only about nipple, so eczema and Paget's disease. Eczema is a skin disorder that can be present elsewhere. Underlying CA breast for Paget's disease. Always important. Eczema will be seen in young individuals, whereas old age is the most common sign for Paget's disease. Eczema is usually unilateral, and eczema is usually bilateral, whereas Paget's disease is unilateral. Eczema is treated by 0.5% hydrocortisone, and it will respond very well topically, whereas you will need a full evaluation for CA breast in a case of Paget's disease of the nipple. Then you have inflammatory processes of the breast, that is mastitis, inflammatory abscess. And another inflammatory feature that can be present in a breast is Mondes disease. This Mondes disease is also called as string phlebitis. String phlebitis. Mastitis, acute bacterial mastitis, is the most common cause of mastitis, and the organism that is involved, like any abscess elsewhere in the body, it is Staphylococcus aureus. Staphylococcus aureus. Staphylococcus aureus is the causative agent. Drug of choice for mastitis is floxacillin, and amoxicillin plus clavulanic acid. That's also called as Augmentin. And what are the features? You will have pain, you will have fever, you will have redness, you will basically have a hardish feature feel in the breast. That is because of induration. In mastitis, in inflammatory abscess, this mastitis will become abscess. And remember, breast abscess is one of the areas where you will not wait for fluctuation. You have to operate the moment you think that the patient is suspecting from abscess. So initial treatment will be needle aspiration. Then you will give a radial incision on the opposite sides to do a dependent drainage. You should remember that all the loculi of inflammatory abscess of the breast have to be broken, and then you put a drain. It could either be called as a corrugated rubber drain or a tube drain. Tube drain is nothing but your suction drain, and close it. And it should always be a dependent drainage. It should always be a dependent drainage. Okay, then you come to Mondes disease. Mondes disease is very, very important. It is called as string phlebitis. Okay, it's called as string phlebitis. Thrombophlebitis of the superficial veins of breast and anterior chest wall is called as Mondes disease. So when you examine, you will have a cord-like thrombosed structures attached to the skin, and it will form a groove when you lift the hand up. When you lift the hand up, you will have what you call as a groove. You'll have a groove. Frequently involved veins, very, very important. There are three veins that are usually involved. The most common vein to be involved in Mondes disease is lateral thoracic vein, followed by thoracoepigastric vein, and then superficial epigastric vein. These are the three veins that are involved. The most common is lateral thoracic vein, and basically you should remember that it is a self-limiting disorder. Self-limiting disorder usually resolves in 4 to 6 weeks of time. Biopsy is advised in Mondes disease. Okay, when you think or when you are suspecting there is lymphatic permeation of underlying CA breast. How do you treat? You have to rest that particular arm, ask the patient not to move it up down frequently. Rest the arm. You will give NSAIDs, you will give warm compression, and you will give a good support. Probably a brasserie. Uh, Persistent and refractory to treatment. If the Mondes disease persists, then you have to go for excision. Then we'll talk about ductectasia or periductal mastitis. This is dilatation of breasts associated with periductal inflammation, most commonly associated with smokers. Classical presentation is dilatation of one or more larger lactiferous ducts which fill with brown or green color secretion. Nipple discharge is present. Okay, nipple discharge is present, and it could be of any color. It could be of any color. Other features are there is a subareolar mass, there is an abscess, mammary duct fistula, and nipple retraction. Okay, other features I already told you. Periductal mastitis is a complication which develops from ductectasia, and it could lead to formation of an abscess or a fistula. Mammography is always advised. Okay, periductal mastitis, mammography is always advised to see if there is any malignancy. Antibiotic treatment is with comatroxazole, amoxicillin plus clavulanic acid, floxacillin, and you should add metronidazole. Hadfield's operation is the treatment option, which means you have to remove the whole duct. Then we'll talk about benign breast diseases, that is called as ANDI. ANDI is very important. Aberration of normal development and involution of the breast is also called as all caps lock ANDI. You should remember the breast is a dynamic structure. Okay, it undergoes changes throughout a woman's reproductive life, and it usually is superimposed with her menstrual cycle, and throughout her menstrual age. Fibroadenosis, fibrocystic disease of the breast, chronic mastitis, and mastopathy are old nomenclatures used for ANDI, and this is called as spectrum of the benign breast disease. The new name coined combining all these disorders is ANDI, aberration of normal development and involution of breast. So there are three types: non-proliferative, proliferative disease with atypia, proliferative disease with atypia, without atypia, with atypia. What are the non-proliferative disorders? Ductectasia, cysts of the breast, apocrine changes, mild hyperplasia, adenosis, fibroadenoma. Okay, whenever fibroadenoma, there should be no complex features. That will be non-proliferative. Then you have proliferative without atypia, that is moderate or florid hyperplasia, sclerosing adenosis, papilloma, complex sclerosing lesion, that's a radial scar, and fibroadenoma with complex features. Proliferative without atypia. Then you will have proliferative disease with atypia, that is atypical ductal hyperplasia, and atypical lobular hyperplasia. Of all the above diseases with malignant risk are florid epithelial hyperplasia and atypical hyperplasia. These include cysts, fibrosis, and hyperplasia and papillomatosis. ANDI is characterized by mastalgia and feeling of a lump. For treatment, usually cyclical mastalgia, nothing is to be done. You should give the patient reassurance. You can apply prime rose oil. Please remember, you should ask the patient to avoid caffeine, not coffee. Innervays of perfect fit. Okay, innervays of perfect fit. Danazol and tamoxifen in extreme cases. Danazol and tamoxifen in extreme cases. What are danazol and tamoxifen? These are your what are anti-estrogens. These are anti-estrogens. Okay. Then treatment of cyclical mastalgia, as I told you, you should have to give the patient a reassurance. You should give the patient a reassurance, adequate support. Okay. Exclude coffee from her diet. Oil of evening primrose 3 months should be given. Okay. And danazole, bromocriptine can be used, and tamoxifen and LHRH agonists to treat cyclical mastalgia. When there is non-cyclical mastalgia, you should rule out chest wall pain like teeth syndrome. Okay, most common in postmenopausal women who are on hormone replacement therapy. Trigger spot identified in local anesthetic or a local analgesic to be injected. Then we'll come to something called as fibroadenoma. Most common benign tumor of the breast. Okay, most common tumor under the age of 30. Second most common tumor in women after CA breast. Okay, then etiopathogenesis. It is said to be a result of increased sensitivity and focal area of breast to estrogen. That's the reason you will see that people who are having fibroadenoma usually are in the age group of teenage and a little adolescent. Why? Because that's when there is hormonal disturbance and estrogen is more. Okay, there are two types of fibroadenoma of the breast, and they are intracanalicular type and pericanalicular type. Intracanalicular type, they're basically inside the canal, the word says, and it is basically a little softer. It's called as soft fibroadenoma. Whereas pericanalicular are outside, and this is called as hard fibroadenoma. So now what is the difference between pericanalicular and intracanalicular? In pericanalicular fibroadenoma, the swelling is usually firm, okay, smaller with an increase in ducts and fibrous stroma, okay, easily felt in the breast due to tremendous firmness, and it is freely mobile in the breast. And as it is so freely mobile, this pericanalicular, it is called as breast mouse. It's usually seen in young girls and adults, that is from the age group of 15 to 30. Okay, they never attain big size. They cannot grow more because of the pericanalicular in nature. They're usually painless, and the treatment is enucleation. Then intracanalicular type of fibroadenoma, they're less firm, they grow to the larger extent, and there's a lot of glandular tissue and duct system, okay, compressed and distorted. Connective tissue is profuse and loose, and it is called as intraductal myxoma. Most common age group is 30 to 50 years of age. They usually attain very large sizes. They grow very rapidly. May be associated with mild pain, okay, because of its large size. Enucleation is not possible, so we have to do a excision. Clinical features: firm, freely mobile, swelling, okay, painless, slow growing. Most common site is on the lower part of the breast. Fibroadenosis, cancer breast are common in upper and outer part. Okay, no discharge from the nipple, no axillary lymph node. Then there is something called as giant fibroadenoma, which is more than 5 centimeters in size. Okay, submammary incision, enucleation is the treatment of choice. What are the investigations that you will do? You will do mammography, okay, which will show well localized, smooth, regular popcorn calcification. Popcorn calcification is seen in fibroadenoma. It's an entrance question. There's so many entrance questions I'm trying to cover here. Then ultrasonography is best for huge breast and to confirm the nature of the fibroadenoma. X-ray chest show popcorn calcification, and then FNAC. Management is nothing but excision, removal the tumor along with the capsule. Enucleation, removal of the tumor leaving the capsule inside. The fibroadenoma can be enucleated or excised by 3 incisions. That is submammary incision, also known as Gaillard-Thomas incision. Gaillard-Thomas incision. Periareolar incision, okay, around the areola, and then a radial or curved incision along the Langerhans to give a decent scar. Then we will come to fibrocystic disease of the breast. Okay, what are the symptoms? Nothing. A cystic change, a swelling. Okay, sometimes pain can be present. Okay, chronic cyst mastitis, Schimble-Schuck's disease, mesoplasia, Cooper's disease, Reckless disease, and fibromatosis. There is no risk of malignancy whatsoever in fibrocystic disease of the breast. Okay, then there is a radial scar. It's a complex sclerosing lesion. Mammography shows irregular spiculations into surrounding stoma. Then there are microcysts, epithelial hyperplasia, as well as adenosis. Radial scars must be excised in order to rule out if there is any malignancy. There is a moderate risk of cancer in case of radial scars of the breast. So it's basically a pre-malignant lesion. Then we'll come to something called as gynecomastia. Gynecomastia, enlarged breast in a male. Okay, it's an enlarged breast in the male. Physiological gynecomastia, 3 phases of life: the neonatal period, the adolescent, and the senescence. The excess of circulating estrogens in relation to the circulating testosterone, okay, when there is an imbalance between the two, that is when you will develop gynecomastia. Usually unilateral type, bilateral. In young people, it is unilateral gynecomastia. In adult, in senescence, it's usually bilateral. In the non-obese male, breast tissue measuring at least 2 centimeters in the inner diameter must be present before you make a diagnosis of gynecomastia in male. Okay, the broad causes for gynecomastia, please remember: estrogen excess, that is tumors of the testis, endocrine disorders, okay, cirrhotic liver, and hermaphrodites. Androgen deficiency syndromes like hypogonadism seen in Klinefelter syndrome, ACTH deficiency, and old age. Then testicular failures, okay, like trauma, orchitis, undescended testis can also cause gynecomastia. And then there are drugs that cause gynecomastia. You should remember drugs causing gynecomastia: DES, digitalis, okay, diethylstilbestrol. That's what I'm talking about. DES is nothing but diethylstilbestrol, digitalis, antitubercular drug INH, that is spironolactone and steroids, both cause gynecomastia. Cisplatin, calcium channel blockers, captopril, okay, clomiphene citrate. These are the things that are causing this thing, gynecomastia. Ketoconazole, an antifungal, causes gynecomastia. If you take OCPs, especially estrogen excess OCPs, you can develop gynecomastia. Flutamide and furosemide, both of them have something that produces gynecomastia. Metronidazole can produce gynecomastia. Grades of gynecomastia, there are basically 3 grades. Second grade is again divided into A, B. So first, mild breast enlargement without skin redundancy. There should be no skin involved, no redundancy. 2A, moderate breast enlargement without skin redundancy. That's mild, here it's moderate. Then 2B is moderate breast enlargement with skin redundancy. And grade 3, marked breast enlargement with skin redundancy and ptosis. How do you manage androgen deficiency? You should correct androgen deficiency. Whatever medication, you should stop them immediately. Danazol is also used, but androgenic side effects are more common because of danazol. Surgical treatment is done for cases not responding for any of the above treatment, like androgen treat and testosterone administration, medication induced if you discontinue and it won't stop, and danazol if it does not help. Then you should think of doing a subcutaneous mastectomy or local excision or liposuction gynecomastia and breast cancer. Please remember, gynecomastia generally does not predispose the male breast to cancer. However, the hypoandrogenic state of Klinefelter syndrome, that is XXY, in which gynecomastia is usually evident, is associated with increased risk of breast cancer. Increased risk of breast cancer. Actually, I wanted to start DCIS, LCIS. What are the factors? Etiopathogenesis of the CA breast in this class, but unfortunately I won't be able to, and I don't want to start and rush it off. We'll definitely be taking in the next class. So DCIS, LCIS, then etiopathogenesis of the CA breast and the genes involved in CA breast, that BRCA1, BRCA2, all those things I'll be covering in the next class. If possible, I'll start CA breast proper, that is invasive carcinoma of the breast proper, and then we'll see where it will goes. Probably 2 more classes we'll finish with breast, and then I don't know what to, most of the classes will have been covered. We will decide. Okay, thank you. స్టాప్ చేయడం అంటే స్టార్ట్ స్క్రీన్ అప్పుడు ఆప్షన్ స్టార్ట్ స్క్రీన్
మీరు మాట్లాడుతూ అది దానంతా అది అవ్వదు.
అదే అయింది, నేనేం చేయలేదు, నేను ప్రెస్ కూడా చేయలేదు దాన్ని. మిమ్మల్ని మీ దగ్గరికి వచ్చిందే అందుకు చెప్దాం. ఇట్స్ హ్యాపెనింగ్ ఎవ్రీ వీక్. నా లాస్ట్ వీక్ క్లాస్ కూడా 80 minutes వచ్చింది, నేను 45 minutes క్లాస్. ఇప్పుడు ఎన్ని minutes వచ్చింది?
ఇగోండి ఇక్కడ దీంట్లో 2 ఉన్నాయి అన్నమాట. స్టాప్ అవ్వాలి ఇంకా మీరు.
ఓకే.
2 ఉన్నాయి ఇక్కడ.